The next session will focus on how telemedicine, AI diagnostics, and new approaches are helping bridge rural-urban divides and making healthcare more equitable. I'm delighted to welcome our distinguished panelists. Please join me in welcoming them. We have Dr. Anupama Shetty, the Mission Director of Biocon Foundation. May I please invite the panelists on stage, please? Yeah. Dr. Anupama Shetty, Mission Director of Biocon Foundation. Ms. Shanu Saksena, the Chief Compliance Officer, Asia Pacific at Haleon. Ms. Smriti Tandon, the co-founder of online Chikitsa Mitra. And Mr. Manasije Mishra, the Managing Director of DocOnline. We have our moderator, Mr. Abhishek Jha, who's the consulting editor at the CSR Universe. Where's Abhishek? Oh, sorry. Yes, ma'am. Please. She's putting the name cards. Please take your seat. Over to you, Abhishek.
Thank you, Neha. And we have enough number of. So welcome to this panelist, and I'm Shanu Saksena, Smriti Tandon, Manasije Mishra, and Dr. Anupama Shetty, and their profile is very illustrious. Their work has been, many of them have been working at the grassroots level, and since this entire concept of CSR universe is to bring the best practices that has been there, which has made some success or which have made some inroads, to bring them and highlight them in our events. And this is what we are going to do today also, and with the advent of technology. In fact, with the advancement of technology, we have seen almost all spectrum of our lives being impacted, being uplifted. Somewhere there are concerns also. So what are those challenges? What are those opportunities which are also there in this tech-driven medicine sector or healthcare sector that we are going to mainly focus today? If I can just start the session, because we have already introduced our panelists. To start with Ms. Shetty, if I can say, your organization works also in the oral cancer in the rural sector. That is one area which has, I think, equal problems across urban rural sector. But still, what are the basic differences that you find among the rural population? What are the reasons? Are those reasons are a bit different from the urban population about the why do they occur their diseases, their lifestyle, their eating habits? Have you found any difference from the urban sector and among the rural patients? What are the reasons that they have been impacted with these oral problems?
Thank you so much. So yes, oral cancer is definitely an issue for India. So we carry almost 1/3 of the global, oral cancer burden, in fact, and it is the #1 cancer amongst male population, in fact, and the third so in female. And but we began this journey way back, like almost more than 10 years back. I think more than that, in fact, 12 years ago. We began with a very simple screening program and trying to just understand what is it that we could do to address oral cancer and and create a meaningful program. So in that sense, I think what has happened is in this program is that we have brought in various inputs, and I think the previous speakers had talked about it, like, how do you co-create, how do you also bring in meaningful technology and not just any technology, and also how do you have a more evidence-based kind of an action, and how do you dig deep, stay the course. So I think all of these, they've applied to our program. And yes, so I just wanted to mention this before I go on to your question, because in this oral cancer program, I think what we've leveraged upon is capacity building. We took in frontline healthcare workers, we trained them to detect oral cancer lesions, and then we evolved an application. And based on this application and the white light images, when you click an image, it's a white light image. So we had a huge bank of these images, 30,000 images, which we gave to Indian Institute of Science. And through that, we were able to evolve a AI algorithm, and this is now going on. It's an app. It's called Arogyo Arohan. It's there on Play Store. And through this now, it'll be integrated into the, the NCD pathway. So a very small thing began that way. And in terms of your question, you've asked whether there was a difference in the rural and urban, or you're asking about what are the reasons. So the reason is, yes, there is tobacco. There is the tobacco industry for certain. We see our heroes, unfortunately, captains, and so many sports. In fact, sadly, heroes also endorsing
film
cigarettes.
celebrities.
Yes. Have you seen a Netflix film? They'll put a small, a cautionary kind of a thing below, but you will see everybody. I think most of the pictures right now have the heroes smoking. So that is obviously one of the reasons. But while that may be a reason in urban centers, I think in rural, it's more, gutka, khaini, and there's tobacco is taken to stave off hunger. So what we find is that at least in community construction workers, for example, or even if factory workers, they'll keep it in their mouth and they'll keep chewing it, like on one side. So these are some of the reasons that actually we find that in fact when we do screening in factories, there's something called submucosal, OSMF. It's called. You can't even open your mouth a little, like this is called oral submucosal fibrosis. So what happens is that we find this at the age of 20 also. So for that to have developed, this child may have started, or this individual would have started taking, consuming tobacco way back. Yeah, so in their teens. So I think for us, the case is very clear that we need to begin not with the adults, but with the younger ones. So for us, a school program and, just making, bringing in awareness about this disease. And so while we're focusing, yes, on the diagnostics and on the capacity building, we have to have a multi-pronged kind of an approach is what I feel, yeah.
I would quickly bring in Mrs. Smriti Tandon. She's Chikitsa Mitra, online Chikitsa Mitra, and with the kind of concerns Dr. Shetty has expressed, it looks like there should be online Bal Chikitsa Mitra as well. But nevertheless, what's the kind of gap, like if you find, because you have been working in both urban and rural setup, while we see that there is a more digital connectivity, intense digital connectivity in the urban sector, that is not that prevalent in the rural setup, but still the problems are there, diseases are there. How do you cope, and what has been your experience working in these two segments through your app?
Right, thank you first of all for having me here. Yes, definitely, as Dr. Anupama Shetty also said, there has been, there's a stark difference between the rural population and the urban population at the end of the day. The main concern being because they've long been deprived. For them, good healthcare has always been a distant dream. It's been a privilege, not a right. And what we soon realized, we've been working in this sector for about 8 years now. And what started as our separate e-clinic models, we soon understood that in rural India, people are more reliant on these unqualified practitioners. So they closely work with this. Any problem they have, they would straight run to these unqualified practitioners for everything. And they'd get their daily dose of medicine and come back with a treatment. In 2-3 days, they would be feeling absolutely fine. And we understood that as a standalone online Chikitsa Mitra e-clinic, we were not integrating with the existing ecosystem that was there in rural India, where our 65% population resides. And sadly, the doctors are concentrated more in the urban areas. So we transitioned from there. We started then working with medical store owners in the rural. And we are now about 500 medical store e-clinics that we've partnered and have them as our channel partners. And we've integrated technology with the existing ecosystem now. So any patient that comes in for any illness, so there is obviously education that is being given to the patient about around health, we are also seeing a lot of women, because traditionally women have been distant from the holistic healthcare and preventive healthcare in general. And they were dependent on a male counterpart a lot to travel to the urban cities. They couldn't travel alone to a doctor or something. And we started seeing a lot of women coming to us and talking about their health in general, which was not just related to the reproductive or gynecologist related, but in general, even non-communicable diseases and things like that. We see a lot of women, girls that are coming to us to speak about illnesses. So it's been quite a journey for us, and it's been interesting to understand how different the rural population really is, and they have their aspirations to be seen by a good doctor. And now I'm happy to say that a patient in a remote area can be 800 kilometers away from a specialist in Mumbai, and we are making a consultation possible for them. So which is definitely a good.
And that is also a necessity because in India, I think the gap between patient and doctor is about
Yes.
1:1500 almost,
Yeah.
which is way below the global average, and that should be there for a.
So yeah, as you said, as per WHO, it should be 1:1000, but India is 1400. But if you go into rural India, you will find
is
that
even
it is
less.
even lesser.
Even less.
So for Uttar Pradesh, where we started, at that point it was 2300. So 1:2300 patients. So obviously there is less doctors in the PHCs as well, specialists, 70% less doctors are there. So that gap needs to be filled, but the gap can only be filled when you are integrating into the existing ecosystem so that you are not an outsider. So our entire concept started from rural India first, and now we are navigating into urban India.
That looks great. I would also like to bring in Mr. Mishra. He's a management graduate, so I would see that though DocOnline probably works in the sphere of providing healthcare to all, but do you also find a great business opportunity there? Because as we discussed, there is a huge gap, availability of doctors, especially in the rural areas. And how come these DocOnline or other platforms that we have been talking can reach out to them, can provide them best of the consultations at least? And what are the kind of challenges that you have seen in the recent years, especially with the tech intervention? I think it must have been a little more comfortable with a lot more AI and other technology being coming in.
Yeah, thank you. Thank you very much. So pleasure being here this morning. I think our focus in DocOnline is really primary healthcare. And in the community health side of primary healthcare, it's about doing simple things that scale, simple things in a low-cost way. So I think that's really the mantra on primary healthcare. And what we feel is that technology plus people is a fantastic way of solving the problem. It's not just technology. Telemedicine is now pretty well known. I mean, in the previous session also there was mention of SICA’25, which is at scale. But actually our interventions are a little bit different in that we feel that if there could be a human element to telemedicine, it transforms the quality of care, it transforms the ability of the system to win trust. Because in healthcare, trust is the main issue. So we've done over 1 million consultations in the last couple of years in rural India, using this idea that there will be a nurse on the ground who is physically present.
Okay.
The nurse wins the trust of the community. She's able to do point-of-care diagnostics. She can do vitals. Communication is vastly improved by having a nurse there rather than just having a purely remote model. So there is a physical nurse who can touch, who can do vitals, who can do diagnostics. She can dispense simple medication. And I think that model has worked really well for us. And we've actually done this at scale. We worked with the government. The UP government, for example, allowed us to transform 10 of their primary healthcare centers into digital healthcare centers. So I think for us and for me personally, I feel that the doctor and patient should never meet in primary healthcare.
Okay.
I think the idea that the doctor and patient should be in the same room at the same time, to me is bizarre and completely unnecessary. And I feel a lot of us are solving the wrong problem, because the problem is not just a shortage of doctors overall in India. The problem is that 80% of the doctors are in urban India. Nobody who studied for 7 years and who has spent so much money, time, energy in becoming a doctor aspires to go and live in rural India.
Totally.
So I think the government also needs to realize this, that they're not going to solve the problem of forcing doctors to work in rural India. the idea is to separate them. How do you get technology? How do you get people to do that? And I'm happy to say that governments are innovating. There is a program that the UP government is thinking of where they will solve the problem of not being able to have specialists through telemedicine. So they're saying that at least in their community health centers, which are obviously bigger healthcare facilities than the primary healthcare centers, they will not aspire to recruit specialists because it's impossible.
Like the doctors will not be there
No,
to
it's
serve in the
impossible.
rural
I mean,
setup.
there are, in the whole district, you might find one gynecologist. And a district is a massive population, right? So, I mean, the very idea that in rural India you're going to have specialists or doctors visiting, to me is bizarre. And it's easily solvable. By having a nurse on the ground. Nurses, by the way, are extremely dedicated. When we started the program and we started hiring our first nurses in rural India, I thought we were going to have massive turnover. And when we had a program where we had to hire about 100 nurses, and I said, my God, I need a couple of HR people to just keep on hiring these nurses because they will all attrite. I thought it was a terrible job because the job involved getting onto a scooter in the morning, going to one village with a big rucksack, setting up a full primary healthcare center in that village, running a clinic for 3 hours, break for lunch, drive to the next village, repeat 3 hours, and then go home in the evening, right? I thought we're going to have very, very difficult to recruit women. We thought it would be impossible to retain people. But we were like amazed because there are no jobs.
How do you take care of the logistics? Because as you said, most of the women are employed or part of this scheme. So how do you arrange the logistics, packing up all the tents or the space, or then
She does it. She's
on
a
the
superwoman.
scooty or bikes? Like
No, our nurses are superwomen. And there's no turnover. They only leave if there is a government job, because that's always aspirational. So and
That's
they're
lucrative also.
They get a government job, they leave, which is fantastic. And the government also hires them because if they interview 10 people and they find one has worked on our program, they will immediately hire that nurse, which is good. But they are superwomen because they get, we pay them full salaries. We don't, shortchange them. So whatever is the legal salary, we look after their health. We obviously compensate for transportation, etc. So it's a pretty good job. They earn up to 15,000 rupees a month, which in the rural sector is amazing. Two male colleagues of theirs will not earn that kind of money in the same village, right? So two of them, two of their family members will not put together earn what she earns, right? So it's amazing. And these people are willing, they're able, and they are clinically equipped to be able to manage the whole operation. So I actually believe that if all the governments and everybody grasp the idea that we don't need the doctor and the patient in the same room, but we need a trained person to help, to translate, to do stuff that a doctor may have to do physically, which he or she cannot do, it works. So that's our model. We love it. And we've helped over 1 million patients in the last couple of years. We implement CSR programs for corporates. We work with governments. But we think it's the right way of delivering primary care in a difficult rural environment.
Okay, so Mr. Mishra, taking cue from your right way of delivering the healthcare services to the rural population, there are many more such platforms that has come in the recent past, and I would like Ms. Saksena to dwell upon that. How does she think that this entire space, I think this entire space of online consultation has started in over a period of last decade. So do you think there are enough regulatory mechanism or enough law that will ensure that it is not just a money minting process or the last mile connectivity that this entire process has tried to achieve? Will also have some robust mechanism that if there are any failures, any misdeeds, the persons will be held accountable?
Yeah, thank you so much. It's a privilege to be here and to be able to talk about the subject which is so relevant. And like the panel was introduced, healthcare touches each one of us. And I represent a healthcare company. So the point you made about laws and regulations, I think laws are also evolving. We are taking into account everything that is coming through technology and AI. We are also learning the entire programs on how the online consultations will work, how without a handwritten prescription, medicine is going to be dispensed from a chemist. We are learning those things. Regulations are also coming along, and lot will happen because that's the way to go forward. And I completely agree with my co-panelist, Mr. Mishra. You don't need to be in the same room to talk, right? So why do you need to be in the same room to be able to consult where there is no contact needed? You can explain your condition, you can get your treatment, and you can kind of have the prescription medicine. Primary healthcare can be taken care of primarily there. Regulations and compliance will come along. I think what we have to thank the government for is the network of electronics that has been set out, where the telecommunication is now so low cost that doing a video call doesn't take a lot of money. I belong to the era where picking up a mobile phone call costed 16 rupees a minute, right? 16 rupees a second or something like that. If you picked it up, 16 rupees gone. So that's how the missed call got invented, right? Today data is everywhere. Even if your doctor can't reach there, roads can't reach there, through the environment, data is reaching. And so people are able to connect to specialists, super specialists, get consultation. So the geographical spread or the rural story is completely finished. Regulations are also in that space. The DPDP Act is in the wings, should be notified very soon before the winter session. Again, all about data, all about making sure that the entire environment is there. However, like all my co-panelists said, the human aspect cannot be missed out. What really comes about to the medical practitioners is that you're now more accountable to make sure that you listen in carefully and you treat carefully, because the other person on the other side has no access to you, is talking through a mediator, through a technology or a person. So you've got to be more accountable for it and take it more responsibly, irrespective of where the compliance and regulations take you. So more accountability, more involvement with the tools of technology will make sure that we kind of get further. Yeah.
And this tools of technology, Dr. Shetty, if I may ask, we have been talking, and Dr. Mishra also said that physical presence of a doctor may not be that necessary, and I agree that for a primary healthcare setup, that is a normal thing. But for the diseases like cancer that you have been working, how difficult it is for a person, especially in the rural setup, to convince him or her that this is a disease that you're going to catch and is going to be very bizarre. You may die. And probably these telemedicine and the kind of consultation that you're going to have on video would help you, because, does it work?
So as far, we never say cancer, in the sense, we won't call it a cancer screening camp, for example. So most of the times what we do is we would call it a general health screening program, and within that then you'll bring in diabetes, there's hypertension, and then there is an oral examination, and we will tell,
How does it happen, in terms of telemedicine, if you can tell us or explain to us?
So see, telemedicine
Screening of cancer.
for screening for cancer. So see, the thing is, and this is in my earlier organization when I worked with Narayana Health CSR, we had worked with Cisco, for example, on a telemedicine platform, and they had several devices which were, part of the entire system at that point in time. So you would have, for example, a digital stethoscope. Okay, so you could hear the heart sounds, S1, S2, S3, and it was very accurate in that sense. And then there was a dermatoscope, so if you had to pick up skin lesions, for example, and even it had, you could upload your, for example, if you have undergone angiography, so those images could be uploaded. So therefore, images being uploaded and you evaluating that yes, it can happen. But I do believe that, like Mr. Mishra mentioned, that while a doctor can consult and look at images, diagnostics, I think the power of diagnostics is very crucial here. And having a first-line cadre of, frontline healthcare workers who are, very well trained, I think that is key. And like you mentioned, nurses going around, what we have done is, we work in tribal areas. So these are, there's no sub-center also in the radius of, say, even 20 to 30 kilometers. So in such areas, we've picked up, community people, from their own communities, and we've trained them. So because it becomes more culturally appropriate, they understand the cultural nuances of their organization and of their community, and at the same time, certain technologies are not accepted. Like if you have to go in certain regions, this is Bili Rangana Tiger Reserve, okay? The Soliga tribes there, they refuse to show their mouth. So how are you going to do an oral cancer screening and such? And there is a heavy tobacco use in this population. There's a lot of alcoholism.
And in the rural setup, there is also gender conformity that a person, like a woman, would not open up to her concerns to avail.
I think the women are pretty dominant. I mean, yeah, this is what at least I saw in the Solika tribes. The women are pretty strong and all that. But yeah, they have their beliefs. You know, for example, in certain other communities, the Kuniba tribes, you know, we work in Uttara Kannada, they wear heavy anklets. ECG doesn't work. Of course, you know, it's not the norm. What I'm trying to tell you is that technology can work, does work. You need, you know, to develop a cadre of individuals who are, you know, attuned to that community. So keeping community in mind, appropriate technologies. I think telemedicine alone is not the answer. I think it's a combination of answers. Like, you know, that's what I just wanted to say here.
So it's just an addition to the many ways.
It's an addition. Like, yeah, technology is definitely an enabler, but I think co-creating, you know, from ground up, because otherwise it will not be accepted. I remember, you know, and this is one thing that I wanted to share with you all. When we began our telemedicine journey, we used to work with another corporate CSR, and they had retrofitted a 20-foot container. You know, and we put up all these retrofitted telemedicine containers across several places in Rajasthan, you know. And I kept waiting, you know, and, you know, we trained people to use it, and, you know, and we put in our folks. There was a nurse, there was a lab technician, all that done and dusted. And I was hoping, okay, this month, I'm sure, you know, people will just be rushing to telemedicine. It was connected to our hospitals and free consultations. All right. Nothing happened. 3 months and we hardly had any traction. And then, you know, in the sense, I went out, you know, into the ground trying to ask them, okay, what's happening? Why aren't you all using this? You know, we have doctors, it is connected to our specialists. Please come here. अच्छा ये था, हमने सोचा ये computer center है.
Okay.
So you understood. So the fact was that how are we presenting the technology to the community?
It's not just the lab technician.
No, so if you're going to put technology out there and think that it's just going to perform, it's not. It has to be.
Opinion leader also has to be
correct. Yeah, and then we reached out to the communities. We told the ASHA workers about it, and you know, and then we engaged them. We took them on tours of the entire you know, the retrofitted unit, and that's when steadily, you know, things started improving. So it's only one part of the puzzle is what I feel. Like, you know, there are so many elements here. It's a complex adaptive system. Multiple things that you need to factor in. Yeah.
But also, Mr. Mishra, if I can bring in you here, your expertise, because you have said like about 1 million patients you have been able to cater. The data that you collect, and there is a lot of data breach that is happening across major platforms, and the pharmaceutical industry would be very keenly, you know, looking forward to having any database that can actually help them have all those research. How do you ensure that these data, which are most vulnerable because they are collected from the people at the grassroots level, are protected, are safeguarded, and their privacy is also maintained?
Yeah. You know, I think, I mean, that's
that
part.
should have come to me, actually.
Of course,
No,
we would
that's
love
okay,
to
you can
have your
answer, you
opinion
can
as
answer.
well, because that's the most pertinent question. And these are the class that we're talking about. They won't mind if their data is taken out from them, and they will say like, whatever.
No,
use it
I think
way.
from a compliance perspective, ethics perspective, is very important that, of course, you know, we talk about informed consent. But more than that, I think we work with NGOs, we work on open source platforms, and we see that there is a, you know, even the servers are kept apart from, like in the sense, only de-identified data set comes to us. You know, so identifiable data sets go to the community healthcare workers because they need to then follow up with the patients. To us, because we are analyzing, like for example, say high risk prevalence areas, you know, in the cohorts that we work in. So I would be looking at disaggregated, de-identified data sets. You know, so it's about how you receive the data. For example, in the oral cancer application, data is inputted, okay, there is a frontline healthcare worker, he'll input the data. It's all identified because obviously they're interacting with the patient. When it comes to the specialist, they don't have any name. Yeah, it's only an ID. So it becomes de-identified. When it goes back to the healthcare worker, it becomes identified. So we had to get into a lot of loops to make this happen. And I think now with Arogya Arohan, which is the Indian Institute of Science has come up with this ABDM compliant, mobile first, offline capable, application. We'd be able to take this and roll it out so easily into any of the healthcare programs, and so that's the effort. Like, how do you safeguard data and at the same time make, accurate diagnosis and also create an evidence base? That's also very important. I hope I answered. And as a pharmaceutical, I would like to tell you, this is a very hot question.
But while I would ask Mr. Mishra to dwell on the same question, what your answer would be. Also, if you have, like ma'am explained, if the data are not ID, they are not named, but you still have an experience or an information about certain prevalence of a disease or a pandemic situation in particular geographical area. And accordingly, you can plan or project or you can do research or send medicine or create a system there. So how does it work? These data you provide for your own company, or you also share with other partners who are also in this field without the knowledge of the patients, or like how does it work?
So currently, I'm happy to say that we're very clear that we would want money only from one person, which is the patient, or somebody who pays on behalf of the patient. So we have not done any data sharing with any third party. And we don't intend to. We don't think that's our business model. But having said that, there is a fantastic data set that's collected. I think the biggest challenge is actually to make sense of the data. It's not very straightforward. And I think that's where we are now exploring AI tools, because, I mean, apart from the million consultations we do for community health, we also do a similar number of consultations on the urban setting for corporates and other people, right? So it doesn't matter if you're rich or poor, the data is still data, is very rich, right? So I think our biggest challenge on the medical side is actually being able to have machine readable data and to have data which makes sense to a machine. And that is, it sounds very simple, but that is the biggest challenge. I mean, I used to run an insurance company. It was impossible. I mean,
keep the data safe.
There was no way we understood nothing of our patients, and we should have understood everything about them, right? So now with AI tools, we are now experimenting and we're doing pilots to see whether can we extract meaningful information from the images, from the PDF files, from sometimes handwritten notes, from, luckily, we've never had doctors writing handwritten notes, but sometimes when external medical reports come in, they are handwritten. Our own doctors, of course, always type, and they have been doing it for the last 7-8 years.
That we have also seen.
But that is for the healthcare industry, this is the biggest challenge, number one. I think it's for insurance companies and, I mean, even for doctors, because they like to write, and it's very difficult to make sense. So I think the big use of AI, in my mind, is going to come really in being able to first really get this data into a shape and form which can then be analyzed.
Legible to all.
Well, not to all, but yeah, hopefully to the small set of users who are licensed to play with it, and to then figure out what insights you get from it. The prevalence of diseases and all are fairly straightforward, what's the hemoglobin there. And there we have shared data with the government, for example, when we ran the government program, and we explained to them that the data we were picking up was quite different from what their surveys were seeing in terms of the prevalence of even simple stuff like hemoglobin problems or diabetes or hypertension. And these are big, big issues in rural India, largely undiagnosed. And you pick up all that in the data.
So like, these hypertension...
In terms of security, I mean, it's more about making sure your servers are compliant, and we spend a lot of money on IT security. But I think it's more the value system of the company. So we would not like to be selling data. And certainly if there is going to be any collaboration data, it has to be completely de-identified. I mean, it cannot be identified to any individual. Right?
So it's an ethical issue that is you have put a self-discipline model on that. There is compliance sector or compliance from the government also that actually holds you accountable for any data breach.
I think you mentioned the regulations are evolving, but to my mind it's very clear that any personal information where you can identify. I mean, whether you're, I'm a banker actually. I'm not a doctor, right? So I'm not.
Of course.
Yeah, but any personally identified data, whether it's a financial data or medical data, is a complete no-no for sharing. And I think the Indian regulation is evolving very quickly, and we will come to the same almost European level kind of standard where
very soon,
where it will be a significant crime and a significant risk to any company that leaks personally identifiable data of any kind.
Okay. While talking about this data, Ms. Tandon, if I may ask, you are providing an online platform where patients come and discuss their problems. Do you also provide these services in terms of mental health? Because if I'm not wrong, it is believed that about 20% of our society suffers from some sort of mental illness or psychiatric issues. So, and how do they open up? Like in a video setup, how do they open up about these problems that they have? Or do you also identify these people in the rural sector? Because in urban setup, we have seen there are a lot of psychiatric analysis, people go for therapy, and it has become a little less stigmatized. But in the rural setup, if you could throw up on some light on.
Right. So as for the mental health in alone, if we talk about, so what we've done is Online Chikitsa was first a platform just catering to the patients, making sure that the telemedicine platform is a commerce one, and it is integrating with the medical store owners to make sure that everyone has good health or primary health at the end of the day in rural. But recently we've come up with a different app for doctors as well now, that is called 120 by 80. And there we've also started onboarding psychiatrists and neurologists where mental health can now also be included. And with the rural patient, to convince them to adhere to the treatment is very important. Because all these treatments, when you go to a psychiatrist or let's say even a neurologist or a dermat, the treatments are really long. And these rural patients are very used to or accustomed to having certain kind of medicines that they feel relieved in within 2 to 3 days, because they're usually daily wagers and they can't have more impact on their work at the end of the day. So now we have this patient relief team that actually counsels these patients upon their first consultation with the doctor to make sure that they are adhering to the prescription that the doctor has asked them to comply with. And these patients can then ask that, I want to now speak with a specialist, or can you transfer me to a better doctor that I could speak about my health? Because in rural, they don't want to just speak about one particular health concern in rural. They are very chatty. So they want to address everything that would be facing in their healthcare if they have any health issue with the doctor, and they wouldn't matter that he's this specialist or he's only a specific specialist, can't handle your concerns, we've seen. So it's been very interesting. So these patient relief team that we have now in-house, these team ensure that the patients open up, and that taboo is slowly, we are trying to remove that taboo and stigma of consulting a psychiatrist. That is not something wrong with you. It is resolvable. It's just that you need to speak to a doctor and get a good treatment and follow the treatment. That is also equally important.
Okay, Ms. Saksena, if I may also ask you, there is yes. So we're talking about this mental health issue, and we are also trying to know the divide or the kind of differences we have in the rural setup and urban setup. We are talking about corporate people present in the room. You think there are many mechanisms to address many challenges in the corporate sector? We have seen harassment, women harassment especially. About the mental health awareness, is there enough of work that is going on? Because with the kind of 9-hour shift and 3 hours of traveling, very little time is left for a person to take care of himself or the family. So is there anything that the corporate sector should also work and have you seen anything happening in the recent past?
Yeah, so mental health actually has, like she mentioned, it's been a taboo. People still don't consider it to be a condition which can be medically treated. They just think of it as a situation where something's just not right. They don't know what is not right, but that's where it is. To your point, corporates have started to recognize this, and in the last, I would say 5 to 7 years, we've seen people actually be very open about it. You can talk about it, you can take treatment about it, and it's become a conversation. Otherwise, it was so taboo that people won't even talk about it, and hence the support was not available. I think now with people opening up, facilities being available, people being very vocal about this, those issues are getting addressed. And from the corporate side, these are things that have been actually, in the priority, because the world is not anymore stable and, everything is happening at a good pace, etc. So we talk of VUCA and Bani and all kind of disruptions in geopolitical situations, right? Which is essentially
Anxiety.
meaning that, yeah, anxiety is going to happen. And hence we need to kind of treat those things as well as people move along. So corporates are doing a lot. I think we need to recognize there's a lot more to be done. And hence that's kind of where we need to go. Particularly, I just wanted to kind of raise, there's no one mechanism which will address everything. You know, we have to have multiple ways of addressing any challenge that we are facing today. The divide between rural and urban can be bridged by technology. The divide between the specialist and the patient, irrespective, can be bridged by technology. But the fact is, people still need to be next to each other. That whole support system to be able to address any mental issues, stress issues, is very, very important. So I think while the corporates will do their part, there is nothing better than support and the human aspect to it.
Support of the near ones and dear ones.
Absolutely.
I think Dr. Shetty also wants to
Yeah,
say a few
I
things.
just wanted to make a point here because you know, both of you spoke about specialists, and so specialists, for an understanding of mental health, it's a whole spectrum, correct? And it can begin, you know, can be as mild as just anxiety or you know, some kind of stress that you're feeling, to like clinical depression or bipolar or schizophrenia and all that. But what is commonly seen, like, you know, is that there are common mental disorders, CMDs as we call them. So we worked with NIMHANS. NIMHANS, as you know, is an institute of National Women working on mental health. And they came out with a program, it is a community mental health program. What if you can take healthcare workers, you know, everyday healthcare workers, train them to, you know, identify, you know, common mental disorders. You can even get NGOs, you know, trained on this. So this is what we did. I think more than 600 plus organizations, you know, they got trained through NIMHANS, and they did it in a very systematic manner. You know, they have modules, 13 modules were designed. This is even, this was pre-COVID. And so by serendipity, what happened, I mean, it's sad, but it happened at the time when COVID came in. We were able to share these modules. You know, there was so much of anxiety during those days, and it really helped communities understand and deal with their, you know, these stressors, understanding self, psychological first aid. You know, these are some of the modules which were created, and it is all about how do you enable community to understand mental health and deal with it, because not everywhere can we have a specialist.
Exactly.
You know, and I think Mr. Mishra also wanted to make a point here.
Yeah, please. I think mental health is an issue which touches every one of us, and you also want to say something on this?
No, I was just saying that, you know, we've ourselves launched a mental health service for corporates, and I think having a remote doctor in mental health helps, because sometimes patients don't want to meet physically. They feel the stigma of being seen outside a psychologist or a psychiatrist's office, or even some corporates have got a room where a psychiatrist or psychologist might come. But there's a huge stigma to walking into that room, right? So I think sometimes the fact that it's impersonal, it's anonymous, it's at your convenience, it's at a time of your choosing, does help. So I think that both psychologists and psychiatrists can be provided along with a lot of other tools. There are lots of other mental health tools where maybe you don't need to speak to a person also. There's also, you know, how do you relieve your anxiety? And there are lots of things you can do without that. So it is an interesting area. And again, something where technology can play a critical, because we will never have again enough psychologists and psychiatrists to treat everybody.
Mishra ji, एक और चीज़ जो मैं आपसे जानना चाहता हूँ कि you said about the specialist unavailability, and your platform is trying to provide them, and you also said that in the rural setup, doctors don't want to go because they have spent so much money, energy, time, and they want to cash up on the investment of past. So in this entire online telemedicine setup, do the doctors that come on your platform, do they do it just for the sake of doing something good, or do they also see it a profit-making business? Because that is something that will hook them, that is a sustainable way to have good specialist doctors on your platform. So how does it work? Is it also rewarding enough monetarily, or it is just a good deal?
You can't scale up any service on the basis that people are going to volunteer that time, right? I mean, our model is very different from everybody else's model in the telemedicine area, in the sense that we believe that We can only provide quality if we control the doctors. So we tend to hire them as full-time employees, and we pay them reasonably well. A lot of doctors have been with us for 4 years, 5 years, because they find it a rewarding career, because we spend a lot of time on training them, exposing them. They have the latest clinical decision-making tools. So both specialists and GPs, they're on our payroll and they get paid. And obviously you've got to pay decent market competitive salaries. And I think by having doctors on our payroll, we can discipline them, we can train them, we can insist they follow protocols. So we are quite unique in that sense, because we have very strict clinical protocols that our doctors are forced to follow because they're employees and they get audited for it. But of course, even other platforms which are using doctors who just come on the platform and they get paid by consultation, which is most of the telemedicine, where the doctor decides the fees and the patient agrees to pay the fees or whatever. Even there, the doctor's got to make money. No one's going to do it. I mean, you will get doctors who will do charitable work for a couple of hours, etc. But you won't scale up in that way.
Of course. And before we wind up, winding up, I would like to have Ms. Saksena to just say, we have seen technological intervention happening in the health sector. India has been leading it from the front. India is also supporting a couple of countries in other parts of the world, especially in Africa and in South Asia also. Do you have any experience of where do we as Indians stand in terms of telemedicine? What are the kind of basic challenges that we are trying to overcome? And how much of government intervention, or is just the people like you who are going on their own with some idea and some funding?
No, so I think we are in a very good space in India where the 3 Ps are working in partnership. The government bit is kind of enabling a lot of stuff, and I can talk about our primary healthcare vans. They go to the rural villages. They are giving primary health care, like Mr. Mishra mentioned. They set up a clinic there and then provide full day service over there. Again, a medical practitioner is on board, a mobilizer is there, somebody who's from the community is there to get them to come and talk. But this forum also connects them to the Ayushman Bharat scheme. That's how, kind of working towards to make it sustainable in the future is very, very important. We can't keep servicing everybody every time and keep, creating the parasitical behavior. We've got to make it independent, make awareness happen. Like Dr. Shetty mentioned, the important thing is create awareness. People are ready to look after themselves, but they don't know how, what is missing. They just kind of circumvent. I'll talk about oral health care, and it's such a neglected area in our human body that it's unbelievable. You go to the rural sector, they'll start eating softer food, not realizing there is a cavity or there is a problem with their tooth which could lead them to bigger ailments like diabetes, etc. and all of that. So softer food is an easy way out, but not go to a healthcare practitioner. So we have 6 of our oral healthcare vans, which again go into the rural areas and educate, when should you go and visit, and they provide oral healthcare on the van itself. The third thing that I think we talked about was talking to children, because we've got to make it sustainable, we've got to make it long term. So all our vans, all 9 of them, have a requirement to do one school camp to change the way people brush, do oral hygiene camps, etc. So that education goes home and they also learn, and when they become adults, they don't have so many ailments. So that's the way we kind of get into the preventive mode. Preventive, government, partnership, all of that will help to be able to make it more sustainable.
So it's quite like catch them young. Ms. Shetty also said the same, that teenage is also something that we should focus upon. I think Shweta is giving me enough hint that it's time to wrap up this session. And thank you all the panelists for this wonderful session. We dwell upon all the subjects from the rural to technology and everything. And it was wonderful having you all here. Thank you.
Thank you so much.
Thank you, Abhishek. Please stay back for felicitations. May I invite Neha from M3M Foundation, and Abhishek would be felicitating from our team. Yes. And we have, yeah. Can we also have a group picture after this? So please come. Huh? Okay, okay.